Good morning, and thank you for attending our DUR board meeting. A few reminders for our meeting today. If you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. DUR board member, please reserve your question until the end of the presentations or ask in the Google Meet chat. For public comment, if you would like to provide public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy.utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you. And with that, I leave it to Dr. Cannon.
Good morning, everyone. We'll call this meeting to order. Everyone should have received a copy of the minutes. Do we have any questions, any changes that anyone felt needed to be made to the minutes? Fabulous. Hearing none, do we have a motion to approve the minutes?
Move to approve.
Thank you, Dr. Breton. Do we have a second?
I'll second.
Thank you, Dr. Siegfried. All in favor, say aye.
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 Any opposed? Hearing none, we will move on. Noon, do we have any housekeeping today?
Yes, we do have a couple of housekeeping items. The first item is Dr. Michelle Hoffman, with her transition in her job, she's no longer on our DUR board. We appreciate everything she had contributed to the board over the last few years, and we will miss her. We are currently actively looking to replace her positions, which is the academy decisions. Also looking for a pharmacist to replace Dr. Judith Turner, community pharmacist, as well as for the position of consumer representative that was previously held by Kuma. So if the board know anyone that would be interested in joining our DUR board, please refer them to me. I would truly appreciate that. Thank you. And I think Dr. Kim Butterfield also have an update for us.
Hi, yeah, I just wanted to mention briefly, some of you guys have heard that we were directed by the legislature to have Milliman, or a consultant who ended up being Milliman, do an assessment of different cost containment strategies for our pharmacy. And that the results of that are actually available publicly now. If you look online, if you'd like, I can share the link. It's actually through a presentation that was given to the Social Services Appropriations Committee. But I just wanted to mention it here because I'm not sure that we had mentioned that it was completed and that the results are now available publicly. I don't know if anybody has questions on that, or if you like, I could pop the link into the chat as well.
That'd be great when I could put the link in the chat, and then those that want to go out and take a look, they can.
Perfect.
All right. Moving on, I will turn it to the University of Utah. I'm not sure exactly who's going to be presenting, but we're going to talk about high-dose therapy and multiple antipsychotics in adults.
Good morning. That's going to be me today. So we'll get started. The goal of today's presentation is to discuss expert opinion and guideline recommendations for use of high-dose or multiple concurrent antipsychotic therapy, and to review utilization of possible high-dose or short-interval antipsychotic therapy in the Utah Medicaid fee-for-service adult population. As you know, antipsychotics are a diverse class of compounds encompassing approximately 26 unique active ingredients, and many are available in multiple dosage forms, including but not limited to oral or transdermal products that are often administered on a scheduled daily basis, and long-acting injectables, abbreviated LAIs, that are administered by a healthcare provider on a less frequent scheduled basis. FDA-approved indications vary by antipsychotic and dosage form, encompassing many different neuropsychiatric disorders, as well as other conditions like nausea and vomiting. While some approved indications are specific to children or adolescents, all antipsychotics can be used in adults. Pharmacokinetic and pharmacodynamic differences between antipsychotics influence the propensity for certain adverse events and potentially effectiveness. Antipsychotics are the primary pharmacologic treatment for schizophrenia. Approximately 20 to 33% of patients are considered to have treatment-resistant schizophrenia, abbreviated TRS, which is typically defined as having persistent symptoms and impairment of moderate severity despite 2 or more adequate monotherapy trials with different antipsychotics. Clozapine is the antipsychotic recommended for TRS by US guidelines, yet there is a need for additional options as it is estimated only about 40% of patients with TRS respond adequately to clozapine monotherapy. Primarily in the treatment of schizophrenia, use of higher than licensed daily antipsychotic doses, which I will refer to as high-dose therapy, or the long-term concurrent use of 2 or more different antipsychotics that I refer to MAP or multiple antipsychotic therapy, has been reported in the literature. To highlight a potential rationale for MAP, we performed a targeted literature search for select expert opinion. For the treatment of schizophrenia in adults, experts described that MAP has been explored in clinical trials and used in clinical practice primarily as a strategy to improve or sustain treatment efficacy or to mitigate adverse events. Experts tended to emphasize the idea of combining antipsychotics with different neuroreceptor properties, such as those active at different receptors and/or with different binding properties at those receptors, as well as differences in pharmacokinetic characteristics. Nevertheless, the efficacy of MAP versus monotherapy is inconclusive. Benefit in clinical trials has been primarily observed in only the lowest quality trials. A possible exception is the combination of a D2 receptor partial agonist, such as aripiprazole, with a D2 receptor antagonist, which demonstrated improved negative symptoms in a subgroup of a high-quality randomized controlled trials as reported by a meta-analysis by Galling et al. 2017. Additionally, a large long-term retrospective nationwide cohort study found that various but not all MAP combinations were associated with a significantly reduced hazard of psychiatric hospitalization compared to various antipsychotic monotherapies. Experts also highlighted potential concerns with MAP, including the possibility of increased risks like drug interactions and adverse events. However, they did not consider the mere potential for adverse events as a reason to discard the option for all patients. Some low-quality studies suggest that MAP is tolerated by some patients. For example, Galling et al. Found no increased risk of all-cause or intolerability withdrawals with MAP versus monotherapy in a meta-analysis of trials. Ultimately, experts suggest that some patients might benefit from MAP, particularly those who have failed multiple other treatment options. Yet experts also mentioned that it may not be necessary for already initiated or stabilized patients on MAP to persist on MAP indefinitely. Results from some RCTs suggest that
Okay.
2/3 of MAP recipients who are not receiving clozapine may be switched to monotherapy without significant clinical deterioration. We reviewed formal recommendations, in other words, those that were assigned a strength and/or level of evidence rating, along with informal statements potentially related to MAP from recent U.S. schizophrenia treatment guidelines, including the 2023 guideline from the VA and Department of Defense and the 2020 guideline from the American Psychiatric Association, abbreviated APA. Overall, the VA guideline made 3 formal MAP-related recommendations, including 2 recommendations weakly in favor of its use, and 1 neutral statement that was neither for or against its use, and 1 informal statement. The APA guideline only provided informal statements that are not clearly for or against MAP. Especially for the APA guideline, we made some inferences about both guideline suggestions based on the tone and the nature of the evidence cited, which I'll discuss on the following slides. The VA guideline is weakly in favor of augmenting clozapine with a second-generation antipsychotic for treating TRS that partially responded to clozapine based on very low level of evidence. They cited at least one systematic review of RCTs showing benefits with aripiprazole, risperidone, or ziprasidone combined with clozapine for improving certain schizophrenia symptoms. The APA tended to emphasize the inconclusive efficacy for augmentation with benefits primarily limited to lower quality trials. They made no formal recommendations for or against clozapine with another antipsychotic, nor for other mentioned alternatives such as augmenting clozapine with electroconvulsive therapy. Yet, speaking to the idea of combining different medications, the APA stated that there is no evidence that combining drugs is any more harmful than using a single medication beyond the common side effects of each drug. The other weak recommendation in favor of MAP by the VA is regarding the option to augment another antipsychotic with aripiprazole to mitigate metabolic adverse events like weight gain. They equally recommend aripiprazole, metformin, or topiramate as an augmenting agent to be used in combination with non-pharmacologic treatment strategies based on a moderate level of evidence, although they acknowledge metformin is the most studied option. The APA did not specifically mention using an adjunctive antipsychotic to mitigate metabolic adverse events, but they generally mentioned adding a medication with a low weight gain liability, which could include aripiprazole or other antipsychotics, or alternatively metformin, topiramate, or a GLP-1 agonist. Notably, while the VA guideline considered potential benefits to outweigh potential harms for these weak recommendations in favor of MAP, they suggested that choosing these options over alternatives should be driven by patient values and preferences. The VA is formally neither for or against treatment of hyperprolactinemia-related adverse events with MAP based on very low level of evidence. While they did not formally specify a treatment approach, most cited evidence was regarding adjunctive aripiprazole 5 to 15 milligrams daily. Guideline authors described that while adjunctive aripiprazole likely reduces serum prolactin levels, it is uncertain whether it reduces hyperprolactinemia symptoms. The APA made no formal recommendations for any treatment option for antipsychotic-induced hyperprolactinemia, nor did they mention MAP for this use. For using MAP to augment response to an antipsychotic, including among people with or without TRS, we infer that guidelines tend to informally prefer alternative options before considering MAP. The VA guideline weakly recommends switching to another antipsychotic after failure of initial antipsychotic based on a very low level of evidence. For patients meeting criteria for TRS, both guidelines strongly recommend a trial of clozapine. The APA guideline emphasized to not delay a trial of clozapine monotherapy in exchange for several augmentation attempts. We also reviewed recent guidance from the Royal College of Psychiatrists of the UK that addressed high-dose antipsychotic therapy, including as monotherapy exceeding the maximum licensed dose or as MAP. They expressed that it's theoretically possible that inter-individual differences in antipsychotic pharmacokinetics, such as poor absorption or increased metabolism, or pharmacodynamic differences could contribute to improved responses with higher antipsychotic doses. Despite limited evidence, they mentioned scenarios in which high-dose monotherapy could occasionally be considered. For example, they considered high-dose oral olanzapine as a last-line option for TRS for people who fail or cannot use clozapine. They also acknowledged that high-dose antipsychotic therapy can be used inadvertently, for example, due to a lack of awareness of the total dose received by a patient or due to poor psychopharmacologic knowledge. Many antipsychotic-related adverse events are dose-related. However, unique patient pharmacokinetic factors could reduce antipsychotic exposure and then the risk of adverse events for some patients. Regardless, providers considering high-dose therapy should perform appropriate screening for safety before use and monitor for tolerability. The APA schizophrenia guideline hinted that some patients might benefit from higher dose antipsychotics monotherapy if they can tolerate the increased dose without significant adverse events. We reviewed various sources to assist Utah Medicaid with evaluating the maximum recommended doses for use of antipsychotics in adults. We reviewed each LAI's product's prescribing information, abbreviated PI, and extracted maximum dosage and corresponding minimum maintenance administration interval. In other words, the most frequent maintenance dosing interval. Refer to Appendix D of the report for those details. Other than the LAI flufenazine decanoate, for which U.S. schizophrenia guidelines listed more specific dosing interval recommendations than the PI, U.S. guidelines did not reference information about using LAIs more frequent than the labeled recommended interval. We are aware of at least one case report of a patient with treatment-resistant schizoaffective disorder whose response improved after administration of more frequent maintenance doses of an LAI than what is recommended by the PI. We also extracted the maximum daily dose, abbreviated MDD, among any listed indications for adults that was referenced by the product's PI, the drug compendia Lexidrug or Micromedics, and the APA and VA schizophrenia guidelines as available for each formulation. Most reviewed sources referenced the same MDD for a given antipsychotic product. You can see that information in Appendix C of the report. The highest referenced MDD was usually for treatment of schizophrenia and/or bipolar disorder and for an on-label use. A discrepancy in the listed MDD between two or more sources was found for 10 products, as shown on this and the next slide. This table lists for products for which a source referenced a higher MDD than that of the PI. I'll highlight details about a couple instances. Most notably, while the labeled MDD for oral olanzapine is 20 milligrams, drug compendia report daily doses of up to 50 to 60 milligrams studied for schizophrenia or bipolar disorder, and I found other sources listing doses as high as 80 milligrams daily. However, the compendia Lexidrug reported that doses exceeding 30 milligrams are generally not recommended. Both U.S. schizophrenia guidelines listed an MDD of 20 milligrams for olanzapine. The APA guideline listed an MDD of 320 milligrams for oral ziprasidone, unlike other reviewed sources that listed 160 milligrams in agreement with the PI, although Lexidrug described that up to 240 milligrams might be necessary for acute management of bipolar mania. While drug compendia referenced a higher MDD than the PI for the short-acting injectable of prochlorperazine adisolate when given intramuscularly, these MDDs were inferred for treating severe schizophrenia. According to the PI for that prochlorperazine product, daily doses exceeding 80 milligrams are rarely needed. For a few agents, sources referenced a lower MDD than the PI, which was usually due to evidence of poor or worsened balance of risk versus benefits at the highest dose for most patients. For short-acting intramuscular injectable chlorpromazine, a very high MDD of 2,400 milligrams is theoretically possible based on the maximum dosage and minimum dosing interval listed by the PI for severe acute schizophrenia or mania. However, the PI listed lower doses of 200 to 800 milligrams daily for long-term treatment. So we also performed a retrospective descriptive utilization review to address two primary objectives, including to assess for the possible utilization of oral or transdermal antipsychotics at higher than recommended daily doses and LAI antipsychotics at shorter than recommended dosing intervals. We elected to focus on the dosing interval for LAIs since they are available as fixed-dose single-use products. We queried outpatient pharmacy fee-for-service claims for target antipsychotic products among the adult Utah Medicaid patients during the observation period. Target products included any oral, transdermal, or LAI mono-ingredient or combination product containing an active ingredient classified as an antipsychotic by Lexidrug, except for droperidol, pimavanserin, and Aristata Initio. The observation period was 12 months, starting June 1st, 2023 and ending May 31st, 2024, for all products except for the LAI Invega Half-Eura, for which we used an 18-month period since it has a maintenance dosing interval of every 6 months. All oral or transdermal claims during the observation period were included for our analysis, whereas we excluded some LAI claims if they were considered to have potential issues with the associated days supply in the claims record. To address objective 1, we compared the average daily dose, abbreviated ADD, to referenced MDDs per product. The ADD was calculated and assigned to each supplied day using the strength, quantity, and entered days in the claim of record for the respective fill. We used up to 2 thresholds that were compiled from the reviewed sources. MDD1 is the MDD in agreement from all reviewed sources. Otherwise, it's the lower of the different MDDs among reviewed sources for that product. Ultimately, MDD1 is the FDA-approved MDD for most products, and MDD2 is the highest reference MDD among different sources. To address objective 2, we compared the entered day supply, abbreviated EDS, of an LAI fill to minimum maintenance dosing interval thresholds per product. The EDS is the day's supply entered by the pharmacy for the prescription fill. We focused on the EDS since we felt that it was probably the best approximation of the prescriber's intended dosing interval instructions. We used up to 2 possible dosing interval thresholds, depending on information available in each LAI's prescribing information. The MSDI, which stands for the minimum scheduled dosing interval, was assigned for all LAIs according to the shortest PI recommended maintenance dosing interval without accounting for occasional allowed early doses. Some LAI package inserts specify allowances for occasional early administrations. For example, allowing administration up to 7 to 14 days early, depending on the product and with respect to the MSDI interval, to accommodate a flexible dosing schedule. Thus, we use the second interval, MAEDI, which stands for the minimum allowed early dose interval, for those products with the PI specified flexible dosing instructions. The MAEDI is the shortest possible interval between administrations per product labeling. During the observation period, we identified approximately 156,000 eligible oral or transdermal antipsychotic claims, accounting for a total of about 4.5 million supplied days from 20,964 unique patients. And I call these patients the total oral or transdermal cohort. Most of the patients in this cohort were eligible for Medicaid coverage for most of the observation period, with a median of 12 months of coverage. Overall, our descriptive analysis suggests that most Utah Medicaid adults probably received their prescribed antipsychotic at a daily dosage within the maximum limits specified in the PI or other sources. However, there were some outliers. Among all supplied days for an oral or transdermal antipsychotic during the observation period, 1.2% had an ADD exceeding the highest FDA-approved MDD for any indication. This encompassed 375 patients, which is 1.8% of the total cohort. Yet, when considering the highest dose referenced among any reviewed source, only 0.6% of supplied days had an ADD exceeding the maximal MDD. This table shows products that had an ADD exceeding the MDD1 for 2 or more % of supplied days for that product, including 2 haloperidol oral products, fluphenazine, 2 olanzapine products, and ziprasidone. While 27.7% of supplied days of haloperidol oral concentrate had an ADD exceeding the MDD1 of 20 milligrams, no supplied days exceeded the FDA-approved maximum of 100 milligrams. Similar trends were observed for other products. In the 75th percentile of the ADD, shown in the second column from the left in the table, also suggests that most of these antipsychotics were dispensed at a dosage at or below the daily reference maximums. Across all products, including those not shown in this table, only the 75th percentile ADD for haloperidol oral lactate exceeded the MDD1, which is still below the FDA-approved limit. We identified 13,000 eligible LAI antipsychotic claims, which was 98% of all claims during observation. Eligible claims were from 1,912 unique patients, which I refer to as the total LAI cohort. Most patients in the total LAI cohort were eligible for Medicaid coverage for most of the observation period, with a median of 12 months of coverage. Overall, our descriptive analysis of the EDS from LAI claims suggests that most Utah Medicaid adults are probably intended to receive their prescribed LAI within the FDA-approved labeled intervals. There were, however, some outliers. Overall, 17.3% of total eligible claims had a lower EDS than the MSDI, suggesting a relatively small percentage of eligible claims could have been for a duration shorter than the typical minimum dosing interval by 1 day or more. These claims with an EDS less than the MSDI were from 353 unique patients, comprising 18.5% of the total LAI cohort. Yet, many of the claims with an EDS less than the MSDI were satisfactory with respect to the MAEDI threshold. 61.5% of those claims had an EDS greater than the MAEDI, thus appearing in compliance with the early dose allowances and product labeling. An additional 28.4% of claims with an EDS less than the MSDI were not eligible for MAEDI evaluation since they did not have an explicitly labeled early dose window. Only 10% of those claims had an EDS less than the shortest MAEDI threshold, which represents only 1.7% of the total LAI antipsychotic claims. For most LAI products, the 25th, 50th, and 75th EDS percentile of claims was near the MSDI threshold, suggesting that the planned administration interval was close to the PI recommended interval in most cases. This table shows the LAI products with 11 or more claims and with 25% or more of that product's claims with an EDS under the MSDI. The 25th EDS percentile for each product was 7 or more days below the MSDI threshold. However, keeping in mind that some may or may not be below the MAEDI threshold. The biggest disparities between the EDS and MSDI threshold were observed for Abilify Asimtufii 720 milligrams that had a median EDS of 30, suggesting that the EDS from half the claims was almost 1 month before the typical dosing interval of 2 months. Yet it should be considered that generally these products were the biggest outliers, and there are limitations to this analysis, including that the EDS is only an approximation of the intended administration interval. Indeed, the limitations of our descriptive analysis should be considered when interpreting the results. Like all claims-based analyses, it's possible that the claims do not match how the patients actually used or were administered the medications. It's also possible that there were errors inputted into various claim fields leading to inaccurate calculation of the ADD or EDS. The EDS is entered by pharmacy staff and may not always reflect the prescriber's instructions, as there may be misinterpretations. Particularly for LAI claims that are to be dispensed directly to prescribers, the prescriber might not write patient-specific dosing instructions. It should also be considered that the count of claims with an EDS less than the dosing interval threshold flags any difference, including if the claim was only 1 day before the generally recommended interval. Given potential limitations of the EDS, we performed a sensitivity analysis using the number of days between fills among all claims from patients with 1 or more claim with an EDS less than the MSDI. The sensitivity analysis found a similar median days between fills compared to the median among claims less than the MSDI for most products, suggesting that the EDS is a reasonable approximation for prescription fill intervals in most cases. Notably, while our dosing interval thresholds are based on the minimum maintenance interval, our sample could have included patients who are initiating an LAI or catching up after a missed dose, for whom a more frequent dosing interval is expected for some LAIs, such as Invega Sustenna products. Utah Medicaid does not currently have any special limits or restrictions to the dose or dosing interval of antipsychotics in adults. If desired or required, Utah Medicaid may consider the following for further evaluation or implementation in the adult population. If point of sale, abbreviated POS, dose limits for non-LAI antipsychotics are desired, consider selecting the overall highest MDD referenced among compendia or guidelines, or the MDD according to the PI. Note that in some cases, the labeled MDD may be lower than that referenced in other sources. If POS fill date interval limits for LAI antipsychotics are desired, Utah Medicaid could consider implementing limits using minimum maintenance administration intervals for the particular product strength according to the PI, with allowances including but not limited to those listed here. Firstly, consider an allowance for flexibility in the billing or fill date interval, such as allowing fills after 80% of the recommended maintenance interval has elapsed rather than 100%. Secondly, consider allowances for early fills as allowed by the PI to facilitate patient adherence and provider feasibility to pick up the prescription. Ideally, overrides would be allowed to accommodate shorter non-maintenance dosing intervals that is allowed for initiation and or missed doses for a few LAI antipsychotics. An alternative to building dose interval limits based on the typical maintenance interval is to use minimums that would prevent very early fills, such as before 50% of the expected maintenance interval has elapsed, although this may still require considerations for some of the allowances we just discussed. If POS restrictions are implemented, patients could be allowed to access antipsychotics at higher dose and/or shorter intervals with clinical justification by prior authorization. Our descriptive analysis suggests that high dose or short interval utilization among Utah Medicaid adults occurs relatively infrequently. Thus, if feasible, retrospective monitoring and direct follow-up with the prescribers to patients with antipsychotic claims with higher than recommended doses or with more frequent than recommended intervals could be considered. For LAIs, it may be prudent to prioritize communicating with prescribers to patients with fill dates occurring significantly before the typical dosing interval and/or to patients with multiple sequential early fills significantly before the usual dosing interval. Such peer-to-peer intervention could help clarify the actual maintenance administration interval for fills that appear more frequent than expected. If POS limits or other restrictions are implemented, Utah Medicaid may consider grandfathering in patients already stabilized on their short interval LAI antipsychotic regimen or high-dose oral or transdermal antipsychotic regimen to support continuation of care and to avoid clinical destabilization. We did not query utilization of MAP among Utah Medicaid patients. Guidance from the RCP suggests that concurrent use of multiple antipsychotics is likely more prevalent than high-dose antipsychotic monotherapy, although some of this usage may be in accordance with recent U.S. schizophrenia guidelines that weakly recommend or allow for MAP in certain patients. If desired, further descriptive analysis could investigate MAP usage in the Utah Medicaid adult population. So thank you for your time and attention. Please let me know if you have any questions.
Dr. Britton, you get your hand up.
I just had a question. You had mentioned one of the options is to change the fill time to 80% versus 100% of the use. I guess I was surprised. I know a lot of medications, I mean, even like our, methylphenidate, that kind of thing, we get to fill it a little bit earlier. Is it really just 100% filled? We have to wait for these meds. They already have a 100%, you're supposed to fill only when you are out. It just means that doesn't give much leeway. I just was surprised by that.
Since there is not currently restrictions on the LAIs, we mentioned that just to bring up that point, but I do believe for most medications that there is leeway like you're describing that are currently. Yeah.
Thank you.
Mm-hmm.
All right. Any other questions or comments? Right. Hearing none, we will move on to public comment. So first on the agenda, we have Teva Pharmaceuticals. Deb, are you with us?
Yes, can you hear me okay?
Yes. You have 3 minutes, and I'm assuming somebody's timing noon.
Yes.
Okay. All right, go ahead.
Thank you. Hi, my name is Mandeep. I'm a pharmacist with Teva in Medical Affairs. I'm here to provide information about UZEDY. UZEDY is a long-acting subcutaneous risperidone injection. UZEDY was approved in April of 2023 for the treatment of adult schizophrenia. UZEDY uses an innovative copolymer technology and has a combination of product attributes that differentiate it from all other LAIs and may be valuable to Utah residents living with schizophrenia today. Therapeutic plasma concentration is achieved within 24 hours following the first dose, meaning no oral supplementation or loading dose is required with UZEDY. This may be beneficial as many LAIs are initiated in the acute inpatient setting, where a loading dose can delay discharge or transition of care. UZEDY can be administered once monthly or once every 2 months at doses of 50 to 250 milligrams of risperidone, comparable to 2 to 5 milligrams per day of oral risperidone. UZEDY is the only risperidone LAI with a 5 milligram oral dose equivalent. Patients can go directly to Q2 month dosing as long as tolerability to oral risperidone has been established. Q2 month dosing does not require UZEDY Q1 month injection prior to use. UZEDY is the only sub-Q risperidone LAI dosed every 2 months. This may also be beneficial for hospital discharge situations, so there is additional time to coordinate outpatient treatment. Receiving an injection every 2 months may allow patients in underserved rural areas or those with other access challenges, such as limited transportation or time off restrictions from work, more flexibility receiving their injections. These factors are known as social determinants of health and may contribute to health disparities. UZEDY is supplied as a single-dose prefilled syringe that can be administered without reconstitution in the arm or abdomen, and it has flexible storage requirements and is stable at room temperature for 90 days. UZEDY was studied in RISE, a phase 3 double-blind randomized relapse prevention study that compared the efficacy and safety of UZEDY Q1 month and Q2 month with placebo across 544 patients with schizophrenia. It significantly decreased relapse risk by 80% for the Q1 month injection and 62.5% for the Q2 month injection compared to placebo. UZEDY was also studied in SHINE, a phase 3 multicenter double-blind parallel group study to evaluate the long-term safety, tolerability, and effect of UZEDY across 336 patients. UZEDY was well tolerated, and the safety profile was consistent with other formulations of risperidone and the phase 3 study. I will refer you to the package insert for complete safety information, including ISI. In closing, I respectfully ask the members of the DUR board to allow access to UZEDY without restrictions in the state of Utah as a preferred drug. Thank you for the opportunity to provide public comment.
Sorry, forgetting how to get myself off mute. Thank you, Mandeep. Any questions from the committee? All right, hearing none, we will move to AbbVie and Bradley Jones.
Can you hear me okay?
We can hear you.
Okay. Well, thank you for the opportunity to provide testimony regarding the use of Vraylar, cariprazine for the approved indication of schizophrenia, the acute treatment of manic and mixed episodes of bipolar 1 disorder, and the treatment of depressive episodes associated with bipolar 1 disorder, also known as bipolar depression, as well as its newest indication in the adjunctive treatment for major depressive disorder, AMDD. This morning, we wanted to just take the opportunity to respectfully request that the committee consider adding cariprazine as preferred brand with unrestricted access on Utah's Medicaid, state Medicaid formulary. The rationale for this request is based on the following 3 clinical highlights. First, Vraylar's safety and efficacy. It has established safety and efficacy in 9 separate clinical trials, 3 trials for schizophrenia, 3 trials for manic or mixed episodes of bipolar 1 disorder, and 3 trials for bipolar depression. And as such, unlike most atypical antipsychotics, cariprazine treats the full spectrum of bipolar 1 disorder, manic, mixed, and depressive episodes. The most common adverse events of cariprazine include akathisia, extrapyramidal symptoms, although discontinuation due to these side effects was 2% or less in the pivotal studies. Cariprazine has a neutral metabolic profile and low risk of weight gain, which is a common side effect with other antipsychotics. Cariprazine does have the most of the same warnings and precautions as other atypical antipsychotics as well. And I encourage you to just review the full prescribing information at rxabbvie.com. Secondly, Vraylar's unique pharmacologic profile. While the precise mechanism of action is not fully characterized, cariprazine is unique among the D3 preferring atypical antipsychotics, having the highest affinity for the D3 receptor, and this receptor pharmacology profile has been theorized to have benefits on the difficult to treat symptoms of schizophrenia, such as predominant negative symptoms and cognitive deficits. And third, Vraylar's long half-life. Cariprazine has an active metabolite called didesmethylcariprazine, or DDCAR, which contributes most of the antipsychotic activity with a long half-life estimated to be between 1 to 3 weeks. And this long half-life suggests that some continued effect may persist after the discontinuation of treatment. And I believe this should be important to you, as it may be beneficial in preventing rapid relapse in patients with intermittent adherence. And this was demonstrated in a 97-week schizophrenia relapse prevention trial where stable cariprazine patients were randomized to placebo or allowed to continue on cariprazine. And in relapse prevention studies with other oral antipsychotics, the relapse rates in placebo groups are typically 15 to 30% over the first 4 weeks. And in this long-term study, the relapse rate in the placebo group was about 3 to 4% after 4 weeks. And this suggests a residual treatment effect that may persist after discontinuation, which may be related to the long half-life of the active metabolite. And this persistence may confer potential cost savings based on some data that was presented at AMCP not too long ago. So in summary, cariprazine is a 1-pill once-a-day medication just approved to treat schizophrenia and the full spectrum of bipolar 1 disorder, as well as AMDD. It has a neutral metabolic profile and a low risk of weight gain. It has the highest affinity for the D3 receptor.
And that's 3
And-
minutes.
Okay.
Thank
Well,
you so much.
Thank you so much.
All right. Any questions from the committee? All right.
James Kennington has a raised hand.
Oh, Dr. Kennington, I do see you. All right. Not hearing a question. We'll move on to Otsuka and Brad Harrison.
Hey, good morning. Can you hear me okay?
Yes, we can.
All right. Well, thanks for your time today. My name is Brad Harrison. I'm a pharmacist and a managed market liaison with Otsuka Pharmaceuticals. And I want to give you, provide an update on indication for Rexulti. And this is in addition to the previous indications for adjunctive therapy in adults for major depressive disorder and schizophrenia in adults and pediatrics 13 and older. Rexulti is now the first and only FDA-approved medication indicated for the treatment of agitation associated with dementia due to Alzheimer's disease. Agitation is a common neuropsychiatric symptom that presents alongside cognitive decline and among the most complex, stressful, and costly aspects of care. The frequent occurrence of agitation associated with Alzheimer's dementia, combined with its serious consequences for patients and caregivers, make it a key target for treatment. The efficacy of Rexulti in the treatment of agitation associated with dementia due to Alzheimer's disease was demonstrated in 2 12-week randomized double-blind placebo-controlled fixed-dose studies named Study 6 and Study 7. In Study 6, it included 433 patients aged 51 to 90 years old. Patients in Study 6 were randomized to an oral dosage of either Rexulti 1 milligram once a day or 2 milligrams once a day or placebo. And in Study 7, 345 patients aged 56 to 90 years old were randomized to an oral dose of Rexulti, either 2 milligrams or 3 milligrams once a day or placebo. The primary efficacy endpoint in these 2 studies was the change from baseline at week 12 in the Cohen-Mansfield Agitation Inventory, or CMAI, total score, which assesses the frequency of manifestations of agitated behaviors. In Trial 6, patients in the Rexulti 2 milligram group showed improved total CMAI scores compared to patients in the placebo group at week 12. And in Trial 7, patients in the Rexulti 2 and 3 milligram group showed improved total CMAI scores compared to patients in the placebo group at week 12. In fair balance, I call your attention to the box warnings for Rexulti. First is an increased risk of suicidal thoughts and behaviors in patients aged 24 years and younger, and increased mortality in elderly patients with dementia-related psychosis. Rexulti is not approved for the treatment of patients with dementia-related psychosis without agitation associated with dementia due to Alzheimer's disease. In closing, Otsuka respectfully requests that Rexulti be available to patients with agitation associated with dementia due to Alzheimer's disease, with no restrictions on the Utah Medicaid preferred drug list. Thank you.
Thank you. Anyone on the committee have any questions for Otsuka and Brad Harrison? All right. Hearing no questions, we will move on. And is there any discussion we need to have about the results and the DUR that Lauren presented on high-dose antipsychotic use? All right. Dr. Weinstein.
Thank you. I know the focus here is on the use of this class of drug in neuropsychiatric applications, but I just wanted to make a brief comment that we see this also a number of these drugs used for physical as well as behavioral symptom management in the hospice and palliative care world. And that might be for outpatients as well as, folks who are residing in facilities. And I know we don't have a lot of data kind of to separate that out, but these medicines have been used for a long time in symptom control, other than for the primary neuropsychiatric disorders. So I just want to make that comment.
Thank you, Dr. Weinstein. And Noon, I know we are talking about antipsychotic use in adults again next month. Are we best holding any potential recommendations and things to that point?
Yes, we are going to review antipsychotic use in adult second part next month. I just want to give a brief background on why we are looking at this topic this time. As again, this is an important drug class used in our utilizations, and also was signing into law of March this year that CMS requiring state to start monitoring antipsychotic use in adult. And that is going to be report in our DUR report. It's going to be amended 2 years from now. That is hence we're going to start some sort of monitoring for the antipsychotic use in adult. It might be similar to what we have for antipsychotic use in children, or it can be less, but that is hence the background of our topic reviewing.
All right. I think we did see some high dose use, but I think, quite frankly, it appeared to be incredibly small and perhaps consistent with the diversity of disease within individuals. So with that, then I will recommend that we move on, deferring to myself. We have a PA criteria to review for Resdifra or resmetirom. Noon, I'll turn that over to you.
Thank you. Look like we have a public comment on that as well. I sent the board the written comment from Dr. Terry Box yesterday. And then we have another written comment from another hepatologist from the U that I wasn't able to send to the board because we don't have the conflict of interest form received yet. But if we happen to receive it later on today, I will forward that written comment to the board as well after the meeting. Look like we have a public comment from the manufacturing themselves, from Dr. William Lam as well. You they want to go first?
Sure. Thank you very much. Can you hear me okay?
We can hear you.
Perfect. Thank you. Good afternoon. My name is William Lam, and I am a scientific director in medical affairs at Madrigal Pharmaceuticals. Thank you for the opportunity to provide information on Resdifra. Non-alcoholic steatohepatitis, NASH, is the progressive hepatitis form of NAFLD, non-alcoholic fatty liver disease, leading to a variety of liver-related morbidity and mortality, including hepatic decompensation and liver transplant. NASH is characterized by steatosis, inflammation, and features of hepatocellular damage that may result in worsening fibrosis. Progressive intrahepatic hypothyroidism has been well recognized to play a role in liver disease, and thyroid hormone signaling impairment worsens hepatic lipotoxicity, driving progression of NAFLD to NASH with liver fibrosis. Resdifra is the first and only medication approved by the US FDA for the treatment of NASH. Resdifra is a thyroid hormone receptor beta agonist indicated in conjunction with diet and exercise for the treatment of adults with NASH with moderate to advanced liver fibrosis, consistent with stages F2 to F3. This indication is approved under accelerated approval based on improvement of NASH and fibrosis. The efficacy of Resdifra was evaluated based on analysis at month 12 in a 54-month randomized double-blind placebo-controlled trial. Enrolled patients had metabolic risk factors and a baseline liver biopsy showing NASH with fibrosis stage 2 or 3 and a NAFLD activity score of at least 4. Efficacy determination was based on the effect of Resdifra on resolution of steatohepatitis without worsening of fibrosis, as well as one-stage improvement in fibrosis without worsening of steatohepatitis on post-baseline liver biopsies collected at 12 months. Both the 80 and 100 milligram daily dosages of Rezdiffra demonstrated improvements on the histopathology endpoints compared to placebo. Monitor patients for hepatotoxicity, gallbladder-related adverse events, and drug interactions with certain statins. The most common adverse reactions that occurred in at least 5% of patients treated with Rezdiffra were diarrhea, nausea, pruritus, vomiting, constipation, abdominal pain, and dizziness. Diarrhea and nausea were the most common causes of treatment discontinuation. In closing, I want to thank the committee for your time and consideration in allowing treatment-eligible patients in the state of Utah access to Rezdiffra, a first-in-class treatment for adults with NASH with advanced liver fibrosis in conjunction with diet and exercise. Thank you, and I'd be happy to answer any questions.
Thank you. Are there any questions from the committee? All right. Thank you very much for your comments. Noon, I'll turn it over to you to walk through the prior authorization criteria you have in front of us.
Thank you. So this is our proposed criteria for Rezdiffra. So the criteria for the approval is all of the following criteria must be met. Is the patient 18 years of age or older? Is the medication being prescribed by or in consultations with a hepatologist? Does the patient have a diagnosis of non-cirrhosis, non-alcoholic steatohepatitis or metabolic dysfunction associated steatohepatitis? For a member with a BMI more than 27, does documentation show that the member has been enrolled in an approved medically supervised weight loss program for at least 6 months and either failed to lose at least 5% of the excess body weight or have achieved 5% weight loss and continue to have persistent abnormal liver function tests or evident for persistent hepatic steatosis on imaging? We're asking for baseline weight and current weight. Does the patient have moderate to advanced liver fibrosis consistent with stage F2 to F3 fibrosis? Does the patient have a non-alcoholic fatty liver disease activity score of at least 4? Does the provider attest that the patient does not have decompensated cirrhosis? Is the medication being used in conjunction with diet and exercise described in the chart? No. Has the patient been compliant in taking stable dose of medication of diabetes, dyslipidemia, and hypertension if applicable? Has the provider checked the baseline liver function test? Reauthorization criteria is the medication being used in conjunction with diet and exercise. Has the provider submitted updated liver function test with the request? Has the provider submitted update chart note demonstrating that the patient has resolution of steatohepatitis without worsening of fibrosis? Has the patient show a one-stage improvement in fibrosis without worsening of steatohepatitis? The initial authorization is up to 6 months and the reauth is up to 1 year. And this PA has been designed closely following the package inserts as well as the clinical study.
So then the one question I had was, we have the question here, does the patient have moderate to advanced liver fibrosis consistent with F2 and F2 to F3? I'm assuming you don't care if that's by FibroScan, MRE, or biopsy. Is that the case?
So no, we actually asking the medication being prescribed by the consultation with the hepatologist, and we just the specialist in determine that factor. And then the question was structuring in yes and no.
All right. We have any other questions? Comments, recommendations? Catherine?
Yeah, so I was wondering if it would make sense to say hepatologist or gastroenterologist. Or is that not typical in this case?
Yeah, and I don't know. I know one of our medical directors did have a conversation yesterday with Dr. Fox and a few others. I know we're pushing towards a hepatologist on our side.
I think it's an interesting point, especially in areas where they might not have access to a hepatologist. I think it's an interesting consideration.
Well, I think, I guess the other question is you may not have access to a hepatologist, but in consultation with, does that, help in those situations? Dr. Weinstein?
Yeah, I was just going to say, and this might not be correct. My understanding, most hepatologists are subspecialized gastroenterologists. My observation, at least in VA, which is, liver clinic essentially is run by gastroenterologists who are specializing in liver disease. So I think we could generalize it. But I think this kind of covers it. If if it's somebody like a general GI doc who's out in, rural areas, as pointed out, they could easily call, and say that they've consulted if need be for this highly specialized therapy.
All right.
And I see a hand up from William Lamb. I don't know if you see that, Eric.
Yeah, I do. At noon, we typically give the manufacturers 3 minutes. And, if there's other questions directed for the manufacturer, then we can hear from Dr. Lamb. Otherwise, my understanding is that we've been at the 3 minutes. Am I correct?
Yeah, that's correct, Eric. So yes, we normally leave the recommendation of the PA to just the board.
All right, Dr. Smith?
Yeah, so on the part about diet and exercise, I think that sounds good. I guess I was wondering if something like if able could be added to it, because I know some people aren't really capable of doing exercise. In some cases, physical mobility limitations, things like that.
Would that fall under a medically supervised weight loss program?
No, that is number 8.
Would that be covered just as described in chart notes, where the person's capabilities and whatever program has been recommended would be detailed? Or do we need to make a modification to that says as appropriate? Or
I would really like to see as appropriate.
Okay, I think that's a good call out. So thank you. All right.
I had one more.
Okay.
While I'm on here, under reauthorization, if you could scroll a little bit, there we go. So do we have any how is resolution defined? Or do we need to define it maybe? Is it pretty cut and dry? Is it not?
That is a good question. So according to the clinical study in the package insert, the efficacy determinations was based on the effect of Redvisa on resolution of steatohepatitis without worsening of fibrosis and one-stage improvement in fibrosis without the worsening of steatohepatitis on the both baseline liver biopsies collected at the 12th month. That was the primary outcome of the clinical study, and we are trying to mimic that in our prior authorization.
Gotcha. I guess it doesn't seem like we don't always say you're not eligible for more if you haven't met, the efficacy criteria in other cases. So I'm just not sure why we're doing that here.
Yeah, I mean, we're not cutting like clear and dry if the patient hasn't demonstrating any improvement. If the provider decided that the patient still need to be on the medication and has demonstrated some sort of not have to meet significant improvement, but some sort of improvement, that patient can continue on the medication.
That makes more sense to me. So could maybe resolution be changed to significant improvement?
I think that's a good point. We don't usually put like outcomes into our PAs. And maybe we say something like clinical, like significant clinical improvement or something to that effect.
Or even just response.
Yeah, and I think I'd be curious in understanding, from some of the experts in this area, because what my understanding is that reauthorization period is a pretty significant thing, in that the hepatologists are in agreement that if there isn't significant improvement, this is not a drug that you continue. And so I think understanding that better, and so Noon, I don't know if that's, we can reach out to Dr. Box or Dr. Charlton. I know there's a few others in the Valley that are well-versed in this.
Yes, I can definitely resubmitting this for additional input from the specialists. Yes. Or what we can do is we can change this into have the provider submit that update chart note demonstrate positive clinical outcome as our generic language on our other PA as well.
I'm good with that, so long as the others in the group. Dr. Weinstein?
Yeah, so I'm just looking here at criteria 3 and criteria 4. So if I understand how this would be interpreted, either the patient's got improvement of steatohepatitis without worsening of fibrosis, or they have improvement in fibrosis without worsening of steatohepatitis. So these are kind of like paired criteria, but the reverse, if I'm reading it correctly. And in criteria 4, the improvement in fibrosis has a criteria there, one-stage improvement. So it looks like this is an or are these all of these reauth criteria have to be met. If that's the case, then I'm not quite sure I understand how, 3 and 4 or 3 or 4.
Thank you, Dr.
And
Wentz.
I don't know. I'm not familiar enough with, what's in all the package to say, but that's how I'm reading that.
Was one stage of improvement also a clinical outcome from the trials?
Yes. Mhm.
Okay.
Yep. So the reauth criteria was supposed to be all must be met. But as the board has discussed, as this is going to be relying on the specialist, we can simplify number 3 and 4 as the positive clinical outcome. If the specialist decided that the patient still requiring the medication.
Yeah, I think then, I think there needs to be something there more specific. I don't know what that is. And I think, you've got Dr. Gilroy at Intermountain Medical Center, and then you've got Drs. Box and Charlton. I think it'd be good if we could follow up with one of them and get their opinion.
Absolutely. I can send this to the specialist and we can bring this back to the board after we receive the feedback.
Perfect.
All right. So moving on in our agenda, we have just under 9 minutes. So we do have a prior authorization criteria for HAE and the treatments there. And then I'll turn it over to you to review.
Thank you. So this is the acute hereditary angioedema. Prior authorization is including the Berinert, the Firazyr, Calpitor, Ruconest. Those are the medication indicated for acute HAE. Criteria for approval. All of the following criteria must be met. Does the patient have a diagnosis of hereditary angioedema type 1, type 2, or type 3, which is the acquired type? Is the medication being prescribed by the provider specializing in the treatment of HAE? Is the patient using the medication concurrently with an HAE prophylaxis medication? Is the patient compliant with avoiding an HAE trigger? Additional criteria. Select applicable information. For Berinert, is the patient at least 6 years of age and older? For Firazyr, is the patient at least 18 years of age or older? For Calpitor, is the patient at least 12 years of age or older? For Ruconest, is the patient at least 13 years of age or older? Does the patient have a history of allergy to rabbits or rabbit-derived product? Does the patient have history of laryngeal attack? For reauthorization criteria, has the patient has a significant decrease in severity or durations of attacks demonstrated in the chart now? Quality approved. For Firazyr, we approved 3 doses of the 30 milligram. No more than 3 doses may be administered in the 24-hour period. For Calpitor, quantity approved is 2 doses of the 30 milligram. If the attack persists, an additional dose of 30 milligram may be administered within the 24 hours period. For Ruconest, 2 doses at the weight-based dose. If the attack persists, an additional dose may be administered at the recommended dose level. There's a maximum dose of 4,200 units per dose. No more than 2 doses should be administered within a 24-hour period. For Berinert, it's only 1 dosing that we approve for. The initial auth is up to 1 year, and the reauth is also up to 1 year. There is a note about the anaphylaxis related to Calpitor, and there's some billing instruction languages.
All right. Thank you for coming in under your 3 minutes. Valerie, you had your hand up.
Okay, there we go. So this is a topic we're actually reviewing in PNT, so I'm familiar with
these agents, and a lot of nuances are jumping out at me that may or may not have been considered when writing this. So I'm just going to go line by line and say a couple things as quickly as I can. So type 3, it might be an old nomenclature for HAE normal C1 INH. So that is actually a hereditary angioedema. It's not acquired. So that nomenclature might have to be changed. And then number 2, providers specializing in HAE might be hard to come by because this is such a rare disease. Many providers may not ever see this disease or may see one case of the disease in their entire career. So we may only have one provider, maybe in Utah, that sees patients regularly with this disease. Is the patient using prophylaxis medication? So not all patients will use prophylaxis medications. If you look at the approved indications for the prophylaxis agents, those are like the youngest age accounted for is 6 years of age and older. So the younger age groups won't be technically approved, although the IV plasma-derived C1 INHs will be used for prophylaxis. And then on top of that, guidelines recommend everyone with HAE to have acute rescue medication readily available. So that is regardless of age and regardless of the type of HAE, especially because emergency departments may or may not have these rescue agents on hand if a patient shows up in an attack. So they recommend the patient to have that on hand. And also they recommend the patient to have 2 doses on hand. And that's regardless if the patient received like short-term prophylaxis therapy and regardless of if they are on long-term prophylaxis therapy. So there's actually 2 types of prophylaxis of management. So if someone is going in for like say a dental procedure, likely they'd want to give short-term prophylaxis. But in addition, since prophylaxis medication may or may not always prevent an attack, the patient should have the rescue medication on hand, 2 doses of that. And then, so I see the age limit, like for Briner, is 6 years and older. So the age limits don't accommodate here patients 6 years and younger, which this disease can manifest, in ages younger than that. And then the last thing I'll say real quick, reauthorization criteria, if the patient needs to show an improvement in the severity or duration. So the acute agents are not approved to prevent future attacks. That's what the prophylaxis agents do. So the acute agents are given at the onset of attack, and they're to remedy that current attack. They don't prevent future attacks or lessen the severity of future attacks, if that makes sense.
Noon, do we need to coordinate this with the P&T committee so that it's consistent with any formulary decisions that are made?
Yes, we can coordinate this with the P&T committee. P&T committee don't normally reviewing prior authorization criteria. They are reviewing the PDL drug classes and place of drugs on the PDL itself. So this criteria will have to come back to the DUR next time and then incorporate the recommendations from the P&T committee into, or the review from the DRC from the P&T into this prior authorization.
Yes, and I'm assuming that ages you have here are based on FDA approved indications.
Correct.
So, if there is someone less than 6, there is always the ability for an exception. None of this is hard and fast and firm. Am I correct?
Correct.
I think I would like to see our criteria be consistent with the FDA label. And if exceptions need to be made by medical professionals outside of that, that can happen.
Yes, we do have off-label criteria that is on the medication coverage exceptions. That is for anyone under or different from the age that was approved by the FDA.
All right. Then we have some PA criteria coming back to see us again next month. And next month, we'll talk about antipsychotic use in adults again. So with that, do I have a motion to adjourn?
So moved.
Thank you. Second?
Second.
Thank you. All right. All in favor of adjourning? I think you can indicate favor by clicking the exit button. But anyway, everyone, thank you. We appreciate you being here this morning. We'll see you later.
Have a good day.